Thank you, Michelle. Welcome, everyone, to Vermont's response to challenges of racism and health. This is the third program in this winter's series put on by the League of Women Voters and hosted by the Kellogg-Hubbard Library. I'm Tom McKone, moderator for this evening. I'd like to thank the library for hosting this series and for recording and posting these programs on its website. Thank you, Michelle Singer, the library's adult programs coordinator, for managing the technology for us this evening. We had a couple of technology snafus, but we worked those out before everybody else came on. Thanks for taking care of that, Michelle. It's going to all go perfectly smoothly for the rest of the evening. Well, we're now 2 years into the COVID pandemic, and one of the very difficult lessons we have learned is that racial disparities in health and healthcare are even worse in many cases than people thought. The Vermont legislature declared racism a public health emergency. And despite increased awareness, there is evidence that disparities in some parts of the country have actually increased during the pandemic. This League of Women Voters series is designed to foster discussion about racism and health and healthcare, and to help us to all be better informed and to be more involved as citizens. The first program in this series in November provided an overview of the factors that lead to health disparities. Last month, the second program explored how environmental policy impacts health status and how housing and land use policies have had a disproportionately negative impact on communities of color. This evening's program looks at whether the declaration of racism as a public health emergency has driven changes to practices, policies, laws, and resource allocation. Another way of putting this is, what are the challenges we face? How are we addressing them? And what are our next steps? In a moment, I will introduce this evening's panelists. After that, they will each spend about 5 minutes giving us an overview of efforts they are involved in. I will ask some follow-up questions, and then they will ask each other questions. We will then turn to you for input. I encourage you to use the chat feature at any time to make comments or to ask questions. The first of our three panelists is Anna Tempesta Noonan. She is President and Chief Operating Officer of the Central Vermont Medical Center in Berlin, which is part of the UVM Health Network. She has been in those roles since 2017. Since 2004, Anna has served as Vice President of the Jeffords Institute for Quality and Operational Effectiveness at the UVM Medical Center in Burlington. She has concurrently served as Vice President of Quality Management for CVMC since 2012. She has worked for the UVM Medical Center in a variety of clinical and leadership roles for 35 years. Anna began her professional career as an RN with degrees from UVM. She completed a master's degree in leadership and administration from Champlain College. And the best part of her resume is, she's a Barre native, and her first job at age 16 was a nurse's aide at Central Vermont Medical Center's Medical Surgical Unit. That's very cool. Kheya Ganguly is Director of Trauma Prevention and Resilience Development with the Vermont Department of Mental Health. She is on several state committees, including the Racial Justice Task Force and the Health Equity Task Force. Kheya has worked as a teacher and trainer for nonprofits, school systems, and mental health agencies, and in undergraduate and graduate programs at colleges. She is a passionate advocate for diversity, equity, and inclusion, as well as social justice, professional ethics, and women's studies. Kheya holds a bachelor's degree in psychology from Northern Vermont University, Johnson, and a master's degree in school psychology, curriculum, and instruction from the University of South Florida. Born in India and raised in India and the United States, Kheya speaks both English and Bengali. We're expecting she'll use English tonight, which is what we'll need. And our third panelist is Monika Ganguly-Kiefner. She is a chronic disease prevention and health equity specialist. She works for the Vermont Department of Health and is based in the Office of Local Health in Rutland. Monika's focus is on health equity for traditionally underserved populations, including Black, Indigenous, people of color, the LGBTQIA+ community, and people with disabilities and low-income communities. She has a diverse background that includes working in urban planning, advocating for survivors of domestic violence, and farming. A Vermont native, Monika has a master's degree in sustainable peace building and a certificate in nonprofit management from the University of Wisconsin-Milwaukee, and an undergraduate degree in sustainable agriculture and environmental studies from Green Mountain College. So we're going to move on to the next stage, and our panelists will each have about 5 minutes to share their thoughts with you before we go into questions. So Anna, would you start for us, please?
Thank you so much, Tom, and good evening, everyone. It's thrilling to see so many people participating tonight. So I'm going to give a perspective of the healthcare delivery system and try to put it, the work we're doing here at CVMC in context with what's going on, both within the state of Vermont and nationally. And I'm going to share a couple of highlights from some recent reports. The first one's from the Federal Office of Disease Prevention and Promotion, the Healthy People 2020 report, which defined health equity as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally, with focused and ongoing societal efforts to address avoidable inequities, historical and contemporary injustices, and the elimination of health and healthcare disparities. A Vermont Department of Health report to the House and Healthcare Committee in January of 2018 noted that health equity exists when all people have a fair and just opportunity to be healthy, especially those who have experienced socioeconomic disadvantage, historical injustice, and other avoidable inequities that are often associated with social categories of race, gender, ethnicity, social position, sexual orientation, and disability. Our nation and statewide demographics are changing. Currently, approximately 40% of our population self-identifies as a person of color. By 2045, those demographics are projected to shift to a majority of US who identify with the BIPOC community. According to the Department of Health's 2018 State Health Assessment, Vermont residents experience barriers to health, equal health based on race, ethnicity, sexual orientation, gender identity, and disability status. The DDH's Behavioral Risks Factor Surveillance System reported that non-white Vermonters are statistically less likely to have a primary care provider, statistically more likely to report poor mental health, more than twice as likely to report rarely or never getting the necessary emotional support, significantly more likely to have depression, significantly more likely to have been worried about having enough food in the past year, and significantly more likely to report no physical activity during leisure time. Non-white Vermonters have also been disproportionately affected by COVID-19. According to a data brief published on the Department of Health's website in December of 2020, the BIPOC community, nearly 1 in every 5 COVID cases in Vermont were among that community. Even though these individuals make up approximately 6% of Vermont's population, so disproportionately, the BIPOC community was impacted by COVID-19. According to the same data brief, the incidence rate for non-white Vermonters is 74.2 versus 26.2 for white Vermonters. Non-white Vermonters are also at a higher risk for more serious outcomes such as hospitalization and have a statistically significant difference in rates of pre-existing conditions. There are similar trends that exist for adults with disabilities and also adults who identify as LGBTQ. As the largest employer in Washington County and the largest provider of healthcare in the communities we serve, we have a deep commitment to advancing diversity, equity, and inclusion for both our employees and the communities we serve. Integrating DEI in all aspects of healthcare delivery is essential to advancing this effort. A few steps we have taken since launching our DEI efforts in August of 2020 include formation of a DEI inclusion DEI steering committee, and the committee represents the diversity of our workforce and the variety of direct care providers and support roles in our organization. One of our first efforts was to develop a commitment statement to ground all these efforts going forward. That statement reads, CVMC recognizes that diversity, equity, and inclusion are essential conditions for high quality care and for an exceptional person-centered experience for care team members, patients, residents, our families, and community. We're committed to an environment that fosters dignity, respect, and empathy, and embraces a person's race, color, religion, sex, national and ethnic origin, age, health status, disability, sexual orientation, veteran status, gender identity, citizenship, or other dimensions of identity. The statement has been endorsed by our board of trustees, our medical staff, and is our core value for our organization. Other efforts over the past year have been focused on raising DEI awareness and educating our leaders, providers, and staff, including unconscious bias education, developing resources that are readily available for our staff, and DEI content that has also been added to orientation to all new employees. This year, we shifted from acknowledging a traditional Christian holiday to acknowledging Martin Luther King Day, one small step in advancing that DEI journey here. At our UVM Health Network level, we formed an Office of Diversity, and we've hired a Chief Diversity Officer to guide our efforts across the network. A gap analysis is currently underway to identify best practices and develop a multi-year strategic DEI roadmap. Educational offerings, including DEI workshops and micro-learnings and onboarding courses, are also under development. These are just a few examples of the work that's underway, and there is still much work to do to close the awareness gap and knowledge gaps that exist both within our employee workforce and within the patients and residents that we treat. CVMC has over 1,700 employees, and we serve over 66,000 people in our region in 24 cities and towns. We have over 400,000 patient encounters per year in our hospital, in our skilled nursing facility, and within our 23 practices. I believe that our commitment to advancing diversity, equity, and inclusion can have an impact on the community as a whole. As mentioned, health equity is more than just health disparities. Health inequities are created when fair and just opportunities for health do not exist. When individuals experience systemic discrimination in their physical, social, or natural environments, which can all affect health outcomes. To successfully tackle these inequities, we need to address structures and systems underlying health behaviors and health outcomes. Focusing on inequities means addressing upstream contributors, including the social determinants of health, and reframing the questions we ask about health of each other. Prioritizing health equity means that we think about our work differently going forward so that we can create better conditions for health. I want to point those on this call to the Vermont Department of Health report to the House and Healthcare Committee in January of 2018. It's a wonderful resource for very specific health equity related data that's specific to the state of Vermont, and it is available on the Vermont Gov website. So I would encourage folks to explore that to get more specific data related to health inequities that were part of the previous studies that were done in 2018. So with that, I'll pause.
Okay, thank you, Anna. And one of the things I noticed, I know it's symbolic but positive, the Central Vermont Medical Center flies the Black Lives Matter flag at the entrance of the hospital also. Our next two panelists, you may have noticed, they have a familial resemblance and similar last names. And yes, they are mother and daughter. And when I was speaking with them ahead of time, we did say Monika, told Monika that I would refer to her mother only once as her mother. So that to answer any questions, yes, they are mother and daughter team. And we will let the mother, Kheya, go first. So Kheya, you're
Good
next.
evening, everyone. Thank you so much for coming and giving me an opportunity to talk to you. One of the things I want to mention about my position as a director of trauma prevention and resilience development is that it was created through statute by the legislature in 2018. And the goal of this position is, if I'm going to really just put it in simple terms, if you're a Vermonter and you're breathing, I should be touching you and helping you build resistance and prevent trauma. So that's a large charge. And a major aspect of it is looking at health and health equity, especially when I am really urging people to understand that mental health is a part of health. It's not something separate. It's not something that's floating around in the air. Part of being healthy is having not only positive mental health, but the support you need to have that. In this country, and really in Vermont, we have many, many barriers to this. We are dealing with structural racism / displacement that affects BIPOC folk, but also affects other marginalized communities and keeps them from having the same opportunity and access that other people do. For example, and I use the term structural racism specifically because I'm talking about the structures that we've created. I'm not talking about systems or people at this point. I'm talking about what have we baked in that we don't think about. So one of those things that I've pointed out, and the state's been really good about changing, is think about every single time that you've been asked to fill out an employment survey about your race, or any time. Why is white the first category? Why it's not alphabetical? It's a small thing, but it speaks volumes to those of us who do not belong to the mainstream community. For people who are in these communities, part of the issue is a lack of trust in this structure and this system. A reluctance to share information, a reluctance to access programs or promises because so many have been broken or so many have been twisted in some way that they don't want to engage. Joey and I saw your question. We know that race is a social construct, but unfortunately, as long as the federal government requires us to gather data, we gather data. And sometimes it does help to sort of look at how things are. There is a fear of being misunderstood when we speak up, and a great deal of trauma associated with this, because we have experienced so many negative outcomes or been misunderstood so many times that it gets to the point where a lot of people get tired and they no longer want to talk about this. And really, honestly, Vermont is not welcoming to people of color, no matter how much we want to tell ourselves that. And I have chosen to live in Vermont. I came here in '85 to go to college and attend Bennington College. And I left for grad school and I chose to come back. I chose to raise my children here because there's so many good things in the state. But it is not a welcoming place to be. I can tell you that I have experienced, my children have experienced overt racism with people catcalling us on the streets and telling us to go back to where we came from. I get pulled over on a regular basis. I have all of these things that happen which impact my mental health, my physical health, and my willingness to accept help for those conditions. I cannot tell you how many negative medical and mental health interactions I have had. And I work in this field and I get it and I understand it, and I still am very careful when I seek out providers. And I do a lot of questions, got the education to do that. So I will speak to you from my position, which is really to build resilience and build connection and reduce racial trauma But I will also tonight speak from my personal experience, because I think hearing lived experience makes it real and makes it understandable. The last thing I'm going to say is one of the big tasks of this position, and it's one I've taken on very willingly and with actually a great deal of enjoyment, is working within the state and then working outside with community partners, with universities, hospitals, nonprofits, and helping them learn how to create equitable, trauma responsive, and healing centered organizations. I do a lot of consulting, I do a lot of training, and I do a lot of work to help people take those structures and figure out how to turn them on their head. And part of that is learning how to do supervision for people. We've all been traumatized. That's the one thing I can say. This past 2 years has been hard on everybody, regardless of what group you belong to. And having a workplace where your supervision is trauma responsive and equity-based helps employees, because we can recruit and recruit and recruit. And I can tell you 50% of the people of color we recruit leave the state within 2 years because it's unwelcoming. And that's a statistic we need to change. So thank you.
Okay, thank you, Kheya. Thank you for sharing both your professional and your personal experiences. That's very helpful. Monika, your turn.
Thanks, Tom. Hi, everyone. Thanks for coming tonight. I also want to give a quick thank you to Anna for covering all that data so that I don't have to. That's fabulous. And also thanks to Kheya for giving the systemic overview. My job is in an office of local health. So I'm going to speak a little bit more at the community level than the systemic level, because that's my perspective, and my perspective is the only one I can speak from. So my chronic disease prevention specialist role is not the only one. Each local health office has at least a 0.5 position for this. Mine is the first one that is specifically health equity focused, though I am very happy to say I am not the only one anymore. Bennington did just get someone who has a health equity focus as a major part of their position. So my health equity focused role here is brand new. So there wasn't really a roadmap for it. I was sort of building the plane as I was flying, and I've only been flying this plane for about 7 months now. So I'm super new. Forgive me for any knowledge gaps I might have. I'm still learning a lot. So far, what it's looked like is, as Kheya was saying, a lot of consulting. There's a ton of organizations that are really interesting in what I refer to as JEDI work, so justice, equity, diversity, and inclusion. So everyone's super interested and wants to hop on here, but most people don't know where to start. And they eventually make their way to me, through people I've already worked with, or through the Vermont Professional of Color Network, who just did what do you call it, like a story piece on the work I'm doing, because they saw it through something else. So I do a lot of consulting with local organizations such as Come Alive Outside, which is an outdoor recreation organization, and Social Tinkering, which is an organization aimed at building social connection to prevent isolation as a major contributing factor to healthy outcomes. So I work with them very closely, and altogether our current large project is launching a Justice, Equity, Diversity, and Inclusion Collaborative for Rutland County. The steering committee for which will be made up of all members of the communities in focus that I serve. So all of our members, there will be BIPOC, LGBTQ, people living with disabilities, and a couple of other underserved groups that we're currently, we're trying to figure out how best to incorporate everyone there. And we're being really intentional in this work because, it takes time. We didn't get where we are overnight. We're definitely not going to dig our way out of this hole overnight. So it's been a couple months in the making here, but I'm really excited. We've had some really great conversations about this. So we're hoping once we get it off the ground that it'll serve as an advisory committee for anyone in the area looking to engage in JEDI work, because what happens a lot of times is if you are the only person of color or the only LGBTQ person that is known in your community, everyone's like, oh, let's go to Monika. She has all of the answers and can speak from all of the perspectives. And that's super not true. So what we're hoping to do is build a council of people who can represent a large variety of perspectives, and also build a resource hub so that a lot of the more common questions we get, like, where do we start? We have no idea what we're doing. We can point people to them, and then they can do some self-education and come back to us when they have more in-depth questions. So that's a lot of the work I'm doing on the community level. And because I'm a Rutland local health office, I mostly stay within the boundaries of the county. And I talk to some people outside of it, but really I'm Rutland focused. So if anyone has local health questions, I would love to answer those. So.
Okay, thank you, Monika. So some of the questions we already you've touched on them a little bit. I'm going to ask you to go further on them. And this, after I ask this question, I'll ask Kheya to start first on this one, then Monika, then Anna. So you have touched on this a little bit, but a little bit more background on this. So last month, the annual report of the state's executive director of racial equity stated that during the COVID pandemic, quote, communities of color have and continue to experience harm at greater rates than anyone else in the United States, unquote. What special steps have you or organizations you work with taken during the pandemic to minimize this harm, and how successful have they been? And you have touched on that a little bit, but I'd like you to go further with that.
I would say it's a work in progress. I think this is something that has been acknowledged by the people who are working on these issues, and they're seeking knowledge and information and looking to change how we do things. Like Monika said, the health inequities and other inequities that are baked into our system have taken a long time to form. As much as I would like to go through with like a big stick and knock them all down and to have them go away, that's not realistic. We need to work from a solid foundation of understanding so that we can dismantle these areas. I can tell you a large part of my position really is focusing on, Monika calls it JEDI, I call it IDEA, and there are lots of acronyms. And I use IDEA because it stands for inclusion, diversity, equity, and accessibility, which is another really important piece when we're looking at how we serve populations who are traditionally marginalized. But I've seen a lot of work starting from that one example I brought up where the state has really gone through, and we have to ask the race questions because of funding and things, but they've alphabetized the list. They're seeking feedback and building relationships with communities, because here's the other thing is everyone has a thing about let's follow the golden rule and treat others how we want to be treated. No, we want to follow the platinum rule, treat others how they want to be treated. Because I can tell you, like for me, I'm from India. And one of the things, though I've given away on it a little bit, is I hate it when people wear shoes in my house. It's disrespectful. And that's part of my culture. My husband, unfortunately, always has to have shoes on his feet because he has baby feet. So we've learned to sort of, he has house shoes that he wears. But so it's things like that. If someone walked into my house and didn't ask and just walked in, or I didn't give me an opportunity to say, come on in, take your shoes off, there's slippers over there if you want to use them, that's how I want to be treated. So the goal of this work and to make it work is to hear from the communities, not the numbers necessarily and not the stats, because again, quantitative or numerical research is a white construct. And we have so few people of color or so few people in other marginalized communities that when you do studies, we disappear. And the only way to find out what we think and feel is to actually talk to us, or maybe do qualitative research, which is based on what people are saying and describing how they feel. So I would say, if nothing else, we are in the early stages, and I'm pushing the boat as hard as I can, as fast as I can. Thank you.
Okay. Thank you. Thank you for sharing the platinum rule. Monika.
Thanks, Tom. So as I said, I've only been at the health department for 7 months. I missed a lot of the really COVID intensive work. I cannot give enough kudos to all of my coworkers who worked through that for 2 years. They're amazing people. And I hope they watch this recording so they all hear that. So from my perspective, going forward, how I engage to prevent further harm or to hopefully move towards healing is our ultimate goal is, like Kheya was saying, a lot of that, listen to your community and engage with them. Because everyone really, I mean, I work in public health. I know we love stats and numbers and all of that, and they tell their own story, but in that you lose some of the human. And I think that makes it almost harder to dedicate yourself to that work if you break everything down into numbers because there aren't faces on that. So what I do in my community work is, so I started by stuffing myself into every single community meeting that I could find an invite to anywhere. So I ended up in some really strange ones, but they've all become really great networking opportunities. And the people I meet there, I'm like, okay, so I know all of you. Who else should I know in this community? And that's how we've been sort of structuring our Jedi Collaborative, is that snowball networking, like, okay, we know all of you. And now who else should we know? And we have focused particularly on the people we're hoping to involve in this collaborative. So the BIPOC community, LGBTQ, people with disabilities. So I joined my local NAACP. I reached out to the Vermont Professionals of Color Network, the Vermont Health Equity Initiative, Outright Vermont. I work with Social Tinkering, does a lot of LGBTQ specific work, and I met a lot of people through there. So what I am working on doing to address all of the, not just COVID-19 issues, but really long, deep historical issues is just centering that voice so we can find that and not lose that in all the public health data that we love to accumulate, which is also super important. So, thank you.
Okay, thank you, Monika. Anna, you did talk about some of this already, but do you have some things you'd still like to add?
Sure. I would say one of the things early on in the pandemic, so March 9th, just for frame of reference of this year, we'll start our 3rd year of our pandemic response here at CVMC and in the state of Vermont. Early on in the pandemic, we partnered with a community collaborative that we have. It's called an Accountable Community of Health called Thrive. There's about 32 social service agencies. Our district for the Vermont Department of Health, their leader is part of that group. And what we did early on in the pandemic is we stood up a community incident command center. And we did that specifically with the BIPOC community in mind, and individuals that had issues related to the social determinants of health, whether it was housing or food insecurity. And the intent with that incident command center that was community-based was to bring more resources to that population early in the pandemic for 2 reasons. One, to make sure they were getting the resources they needed to early on from an information standpoint, but also from a care and treatment standpoint. And also to make sure that they were being supported in the community early on, so that we weren't having patients come to our ED for care and treatment. We were in the early throes of COVID response. I think that was a relatively innovative practice, and kudos to my community partners for coming together with that model in mind. The other thing we did when we started rolling out vaccinations, and we did about 35,000 vaccinations in a vaccination center here in Berlin, we set it up in the mall so that it was easily accessible to people. It was on the bus line as an example. But we knew that having a place that was accessible was probably not enough in getting vaccinations out to the community that we served. So we worked with our district office and the leader there, Joan Marie Misak, to develop some strategies to get fan out into the community, into neighborhoods. At one point, we literally had teams going door to door and asking if people wanted to be vaccinated. And I think that kind of outreach work, it's sort of going back to the past when we literally went to people's homes and provided care. We also partnered with our visiting nurses in our community at Central Vermont Hospice and Home Health. They were very, very active in going into community, into the homes of their client base and into the community. So I think all of those efforts were just a few ways in which we tried to sort of right the inequity cart of COVID that was clearly impacting the community that we serve here at Central Vermont Medical Center.
Okay, thank you, Anna. Okay, this question came to me from a couple of people, different versions of this. According to the headlines, Vermont seems to have workforce shortages in a number of areas. In particular, employers are having difficulty hiring a more diverse workforce. In healthcare and beyond, what are the key barriers to recruiting a more diverse workforce in Vermont? And we'll start with Monika on this one.
Perfect. So I think a lot of, the difficulty stems from Kheya said at the beginning is Vermont can be a not welcoming place for people of color. So in some of the initial meetings I joined, there's this idea that if you're new to a place, you don't know how things work. So your opinion isn't as valid. So some of the tables I joined that I don't participate in as much anymore, it was, oh, you're new here, so you need to sit down and, be quiet was the gist of it. And that sort of silencing happens to people of color all the time. And I think when you're coming into a workplace or you're asking people to come into a workplace, a lot of what happens if you enter that place as a person of color and you experience microaggressions like, someone saying, oh, where are you from? Or where are you really from? Or, your natural hair is beautiful. I love it that way. If you bring that in a lot of cases up, you sort of risk sounding like that angry brown person. And then people not taking you seriously. And I'm not saying all Vermont, organizations do that at all, but it exists and it's real. And that's a barrier. Also, like I was saying, I think it was 50%, right, of the people of color we bring into the state leave, either because it's not welcoming, they don't feel safe. And there's, a large swath of our population who believes racism isn't a problem. So when you move to a state and they're like, oh, racism doesn't exist here, that's a really big feeling of erasure when you're like, no, I walk down the street and I experience this every day, or my sister does, or my mother does. And that kind of erasure makes it maybe not an ideal place to exist. So I would say even before employment, we need a culture shift. So I would say that's probably our biggest barrier there, is that culture of being unwelcoming.
Okay, thank you. Anna?
Yeah, I just want to echo what I heard Monika say around the importance of really changing the culture. And I think that starts with education and increasing awareness. There's such a level of unawareness around some of the microaggressions that Monika was describing, that there's just almost a level of naivete around it that we've seen even within our own employees. So we're focusing a lot on just educating around unconscious bias and what does a microaggression look like? What does it sound like? And you just heard some pretty impressive examples that Monika shared that she's experienced herself. That's not uncommon. From a recruitment perspective, to your point, Tom, we're in healthcare and particularly very challenged with workforce issues. And so recruitment and retention is something that we're very much focused on. And when we recruit individuals from outside the state of Vermont, that if they are a person of color, we're trying to support them in a number of different ways. Because it is challenging in all the ways that you've heard Monika and Kheya represent. And they're sharing those experiences, and it's very powerful to hear those stories, and very centering and disheartening. So for us, it's really about educating about what those microaggressions look like. How do we raise our awareness? and educate ourselves around the unconscious bias that we have in a state that's predominantly, white and mainstream Christian. So I think we have a long way to go. So it is about shifting that culture and climate in the state of Vermont. And I think as one of the largest employers, certainly in our community, if we can shift our own internal population, that's a huge impact for Central Vermont. And I know that other health systems in the state are also focused on this work. So the power of that moving forward is just one small way to begin to shift that culture.
Okay, thank you, Anna. And Kheya?
So yeah, I spoke about this a little bit earlier, and there are things that we can do and that I advocate for to help recruit and retain. And I really focus on retention because yes, we have workforce challenges in mental health in almost every field right now. We're dealing with baby boomers retiring. We're dealing with a shortage of trained people, and we're dealing with salary issues. A lot of these jobs don't pay what people want to make, especially in mental health. So trying to recruit can be challenging, and those are all issues that are being addressed in different ways. But I want to speak to retention because there are things we can do right now. And one is, as Anna said, it's education, and it's teaching your staff that it's okay to question yourself. It's really hard. Okay, I'll be the first person to say it took me a long time to learn how to call people out in a way that was polite. For example, my name is Kheya. People have called me Kheya, Kheya, Kayla, Kenya. My husband's uncle still calls me Kenya after 30 years. But I've learned to always, as much as possible, without interrupting people at least, correct that. Because that's part of a microaggression. Yes, my name is different, but it's not that different. If you listen, it's Kheya, 2 syllables, sounds that everybody knows. So it gets to the point where, I stopped doing it for a while because I was tired. And that's the honest truth. And that's what other people face. They come in here and they're like, okay, so I don't have a super common name. How many times do I need to correct you? Or the other one that I get a lot, oh, you're so well-spoken. I'm like, what? Did you expect me to sound like an idiot? Or you don't have an accent. Well, I grew up in Pittsburgh. Why should I have an accent? It's just based on how I look. So we need to look at those things that we are doing. There's a great video on YouTube. And if you search it with microaggressions and mosquito, it's an animated short that really resonates with us in Vermont because we all have mosquito issues. But it really draws a clear picture of what microaggressions are. But we can do things like be aware of resources for people. Businesses can have their HR department put together some resources or look around, like Vermont Professionals of Colors is creating that. But what are grocery stores, like Indian grocery stores, Hispanic grocery stores? Who do you know that can cut Black hair or cut Asian hair? There are just so many things that I know, and that's one of the reasons I'm so busy running around the state and consulting with people to share this information, because we can increase retention. It can be as simple as set up a mentoring program, an unofficial, not from a supervisor, but from a peer. And if it's a peer of color, even better, to help people who are moving into the state learn and understand and see what's happening. There are things we can do. I have a lot of hope for this improving and for things changing. It's why I do this job.
Oh, thank you, Kheya. That my follow-up, you just answered my follow-up question, which was going to be, how can we support people of color in the community and people who are already working and living in Vermont, but also people we recruit into Vermont so that we can keep them here. But,
I think the other piece I want to add to that then is the one thing you can do is, if you work with someone of color, is be willing to have an honest conversation, because there are so many microaggressions we let pass just to let it go, and have a conversation and say, I'm learning, I'm educating myself, and I've realized that I may have done things in the past that could have offended you or hurt you. From now on, if I do that, I'm giving you permission and I'm telling you, please call me out. Please help me be better. Because there's nothing stronger than a person willing to admit where they're weak. and where they have challenges and ask for support. But the other piece is, do not expect us to do the heavy lifting to educate you. It gets tiring being the person of color that everyone looks at. I have volunteered for that role. That's why I sit and do what I do. So questioning me and asking me questions, it's an integral part of my job. But for most people of color, expecting them to educate you isn't helpful. But I think it is helpful to say, please call me out if I do something.
Okay, thank you for that. Monika or Anna, do you have any points you'd like to add? Kheya gave us some great examples, but do you have any others you'd like to add?
I can jump in there if you don't mind, Anna.
Go ahead.
Perfect. So as Kheya was saying, be totally open for that correction. A lot of times when I've corrected people, the response is, oh my God, I'm so sorry. I didn't mean to. That was a terrible thing. I'm working on it and I just don't know where to do or what to start. And it goes on and on and on. So my big thing is if I call you on, hey, just because I'm Indian doesn't mean I want a whole list of all the Indian food you've ever eaten in your life. Please stop. Is to say, oh, I'm sorry. I will work hard to not do that in the future. And if I ever do anything like that again, please call me on it. So apologize once briefly, move on, and educate yourself, I would say, is a huge one for me to make people feel supported. Again, as Kheya was saying, the mentorship program, I'm a huge fan of for different workplaces, especially not having it connected to the supervisor, because in a lot of cases, it's the supervisor that's a problem. If someone's having a problem in the workplace, or if they're like reporting microaggressions and nothing's being done about them. If you have like a blind mentorship, I think that's a super helpful thing to have if you're trying to keep people on board. And then I would say just be willing to step back and center BIPOC voices and know that when one person of color is speaking, they're not speaking for all people of color. So I have a way different lived experience than someone who is Black or someone who is Indigenous. So I can't speak from those perspectives. So just know that, if you're asking for education and hey, I've volunteered myself for a position where I educate people. So I get paid to do this. I'm fine with questions, but just know you're getting, that person's perspective, not the perspective of every BIPOC person who has ever existed.
Yeah, and I'm going to build on something you said really quickly, Monika, if you don't mind. The lengthy apology is an issue because what it does then, it puts the burden on the person who may have experienced the microaggression to take care of your feelings and make you feel better. And that's not their job. Their job is to call it out, help you recognize it, and then move on. If you spend 20 minutes apologizing, what you're really doing is saying to that person, oh, I am so sorry, I'm emotionally distraught, you must make me feel better. That's the message that gets conveyed.
Thank you, Kheya and Monika. Anna, they've covered a lot of examples. Do you want to add any?
Just amplifying the notion of peer mentorship. I think that's really, really important for all the reasons that both Monika and Kheya have already described. It's just really important as you're coming into an organization to be able to have a conversation with someone that you can really connect with. And so we're testing that model here with one of our newer senior leaders is a person of color, and they're very graciously offering to support junior members of our team that are also of color, so that they have a peer mentor that they can relate to, and also someone who's navigated some of the base issues that have already been mentioned. Where do I get my hair cut? Where can I find the foods that I like to purchase and buy? In the community, where do I find those resources? So, okay, I'm going to be tapping into you after this just to get some of your resources, as we don't want to reinvent the wheel. But those kind of supports are incredibly important to our BIPOC community, for sure.
Okay,
Sure, and Anna, feel free to do that, because one of the beauties of what the legislature did is they mandated I work with hospital systems in the law, but they also made me free. I'm a free resource that people can tap for resources, for training, for recommendations, or for just brainstorming with somebody who may have experience or knowledge in an area and you don't want to take it to a big group yet. So that's what I'm here for. So please take advantage of it.
Thank you so much.
So we're going to continue for the next maybe 10 minutes, just with the three of you, if you have questions you'd like to ask each other. And for everyone in the audience, if you do not already have chat open, you can go to the bottom of your screen and put the cursor down there, and there'll be the chat option will show up if it's not already showing, and you can click on that, and it will be on the right-hand side of your screen, and you can see what questions and comments people have made. For example, the microaggression in mosquito YouTube, someone put up the YouTube address for that. So, and there's some other information there. So, so Monika, Anna, and Kheya, do you have questions you'd like to ask each other? You started doing that already, but do you have more you'd like to continue with?
Go ahead.
Go ahead.
No, you go ahead first.
Okay. Monika, I had a question for you around your role when you shared that you were one of the first in I don't know if you were the first in the state to fill the role that you're in. Do you know if every district office has a similar role at this point, or are they still evolving?
So every district office has a chronic disease designee for at least 0.5, and they work on, all the traditional chronic disease prevention things, you think like asthma, tobacco cessation, cancer, etc. Mine is the first one in the state that is specifically focused on health equity within chronic disease prevention. And I've sort of taken that in my teeth and run with it because I believe like everything relates to chronic disease prevention, especially when you're looking at the communities I work with, like chronic stress, which I would argue pretty much everyone I work with lives with on a daily basis, is a huge contributor to chronic disease. So I am the first one that's health equity focused. Bennington just hired someone. I don't think she's exclusively health equity, but it's a really big chunk of her job. So my dream someday is that I have a whole army of health equity minions in each office, and we work together to make the state a more just and equitable space. That's an ongoing argument. So we'll see how far we get, but there is interest. Other district supervisors, I think, have reached out to our district director, Renee, to learn a little bit more about my role, because she really is amazing, and she is the one of the driving factors behind the existence of my position, because she saw a need for this and argued really hard for it. So also kudos to her for really putting her, I guess not technically her money because it's state money, but putting the district's money, where their mouth is. So there's like really a focus on it in Rutland, which I'm very excited about.
That's
Monika?
great.
Oh, sorry. Monika, could you talk a little bit, because I think you know more than I do, also about the new health equity positions that are being created?
I don't know tons about those. I know they're funded mainly with COVID money. They're limited term positions that are focused on different aspects of health equity in the state. So I believe the health equity team leads, they're hiring 5 of them. For different areas like maternal and child health, emergency preparedness, local health. And there's another related position that I'm forgetting the name of because state titles are like this long. But it's something about like community engagement and communications in health equity. I'm not sure how many of those they're hiring, but it should be super exciting. I think they're mostly based in Burlington. I am not 100% sure on that, so don't quote me on it. But if they are, like, that's another thing I aim to do in my role here is decenter Burlington from the center of the state, and also within Rutland, decenter Rutland, because while Rutland is important, we do have a lot of people who live not in Rutland. So we're trying to, part of what we're doing with this JEDI collaborative is, how do we bring the rest of the county in? Like, how do we invite those voices also? Because I feel like a lot of what happens is, the only place people know in Vermont is Burlington, and it's fantastic. But it's one of those things where, like, when I lived in Milwaukee, everyone's like, where in Vermont are you from? And I would say, oh, Rutland. And they'd be like, oh, is that close to Burlington? Relatively, yes, I guess, if you're in like terms of distance, but no. So I want to, draw attention to the rest of us too.
So, and
Sorry, that probably wasn't a super great answer. But
No, I
the
thought it
longest
was
part is
good.
that's what I know about those positions.
It's more than I know other than their titles and they exist. So I was reading the chat while you're doing this, and here's one thing I just want to caution about. I think it's wonderful, and I know about the trainings Dr. Avila has been giving, and I think it's great and it's a start. But relying on 98% of the participants or 100% of the participants saying, I will be able to incorporate structural competence and cultural humility after a one-shot training is asking a lot. And people will say that in the moment, and they will take pieces, they may take pieces of it, but a lot of it gets left behind, which is why I really talk about we need to work at an organizational level to make change. And this is part of it, offering the trainings and re-offering them, which I think is great because we're getting 9 more, and that's what we want. We want that building, like when you build a house, you start with a foundation. And when you build a company, you start with an idea. This is sort of the same thing where up to now, a lot of people have given a lot of talk. Well, I had a training on that. Well, I'm happy for you, because so many times we go to trainings and we forget, or we're human beings, we can't retain a 4-hour training and all that information. So this is beyond training and education. This is, like I said, looking at our structures and how does that discourage health equity and how does that harm marginalized populations, and what are we doing in way of, for example, one of the things Anna said, which I loved, because, and it's not that she was wrong, so, and I'm not picking on you, but she talked about leisure time and how BIPOC folk don't engage in as much leisure time. How do you define leisure time? That's my question, because that's one of the things I talk to people a lot when I talk about self-care, because self-care is a very white model. For me, leisure time, really honestly, if you want me to relax and have pleasure, and Monika, I'm going to pull on you because you can attest to this, is I will spend all day, Saturday or Sunday, cooking up a storm to feed anyone who walks in the door that night. And by the end of the day, I'm usually smiling and happy and relaxed. I'm tired, but I'm relaxed because cooking is self-care for me. But other people are like, well, that's work. You're taking care of others. My culture is collective. Okay, it's not individualistic. It's not putting the one first. It's putting the community or your family first. And when I can do that in a way that brings me joy, that is self-care.
Okay, thank you.
Can I add a really quick comment off
Go
something
ahead.
you said? So it goes back to that survey thing, because I think I was just taking a survey today, so I was thinking about this. The like numbered scales, or the yes, I'm more competent, or the no, I'm not competent, or I don't feel like I learned anything. So I understand that those are easier to get answers to and probably mandated by a lot of funding. That's how you ask it. And what I would love to see in that kind of thing is like a reflection based questions rather than like a numeric scale. Like what did, reflect on what we learned today. What are some ways you can apply this? So it's that more applied knowledge rather than the yes, I feel competent. Because like, what is competence?
Yeah.
What does
And
that mean?
who's going to say no, really?
Right? Well, I might say no if I didn't feel competent, but
You might, but most
it's
people.
also like, yeah, how do you define that? So I'd love to see, surveys that gather the information they need and are also, further the education a little bit. I don't know how you would do that. I don't design surveys,
Yep.
but it would
Thank
make
you.
me happy.
So if you haven't been reading chat, there's a lot of additional information about the survey and some of the other things we've been talking about. The Crystal put in the address to health.vermont.gov for people who want to go there. And Kheya and Monika both put their email address in if you want to contact them for any follow-up questions. One of the questions, Anna. So here's a question for Central Vermont Medical Center. Do CVMC electronic medical records use race-based correction factors?
So I'm gonna have to ask someone to help me understand what is meant by race-based correction factors, because that's not a term that I'm familiar with.
So
So I don't know if
Danielle
Tom-
asked the question. Danielle, do you want to give any follow-up? A little more direction on the question? I'm not sure if this is what she's talking about, but I know, and Anna, you've probably read and know about this too, but there have been concerns about studies that have been done on white people and not considered people who of different cultures and different races. And then sometimes the information hasn't been correct for people who are not white.
Right.
Also a piece where they
complicated
give
issue.
different rates. So let's say you're doing a study. I was just looking at some data about this, where they were looking at percentage of kids who faced trauma, and they came up with a raw percentage. So this is what percent of the people who answered the study actually said, and then they came up with a weighted where they took in certain factors or other pieces and changed the percentage based on those factors. So the actual percentage might have been 40%, but when they added some weighing factors, and this is statistical and above my head, but when they added those factors in, it actually lowered the percent. So while it was statistically correct, it might not have been a reflection of the actual experience.
Mm-hmm. Well, what I can offer is that I think we in healthcare in general have a long way to go to make sure we're capturing enough specificity in the data we're collecting. So we're just starting to inventory across the UVM Health Network how we're capturing data related to ethnicity, gender identity, gender bias, sexuality, all of those pieces. And so we've got a team that's beginning to look at that. We do have an electronic health record that's across most of the network now, and we're working with that particular company to see how we can make that data as refined as possible, so that when we do pull outcomes data from that system, that we're not factoring in the way Kheya was describing, where we're using some mathematical equation to try to get to how does this impact a subset of our population. So I think that we're early on in that work, to be honest, as a health system, with trying to collect enough detailed, refined data in the variety of ways that we can to make sure as we're pulling data out the back end that we can adjust for the different variances that exist within our population. But I would say that across the board, we're in the infancy stages and in that type of data collection.
Anna, they put some stuff in the chat that you might understand, and also my name is pronounced Kheya. There's no L in there.
Yes.
Thank you.
Yes, Danielle put some additional information in, very helpful information in chat. One of the things she included from Stanford Medicine, in pulmonology, specialists measure lung capacity with a machine that is called a spirometer. I hope I pronounced that correctly. That is programmed to automatically apply a race-based correction factor to the reading, lowering a normal reading for a Black person by 10 to 15%. So as a result, that would be considered normal for a Black person. It could be considered unhealthy for a white person. Thus, a Black patient may suffer a delay in care and receive inadequate treatment. So that's one of her examples on that.
Yeah, that's very helpful. Thank you, Danielle. I am not aware that our instrumentation does that, but I would have to explore that further.
One of the other, let's see if we can find this one again. Oh, a comment about this is that BIPOC is not a singular, not a single identity, which we know, and we use that culturally. We've been using that phrase. I have personally, I have concerns about it because it seems just like an acronym that is meant to be very inclusive, but doesn't really deal with any of the individuality, just like with people who are Latino or Latinx or whatever. But this huge variety of people. So yes, BIPOC is not a single identity by any means.
No, but it's a useful way for us to be able to talk in shorthand sometimes, when
Yes.
possible. If I'm talking about a specific community, whether like if I'm talking about Black, Hispanic, and Asian
Yeah.
communities, I say that. If I'm
Right.
talking more generally about people who have been classified in a race, I use BIPOC.
Yes.
So when I can be specific, I am. And I'm
Yes.
Monica, what do you say?
It's basically same along the side of that. I tend to like BIPOC more than just the POC because I feel like it really centers the Black and Indigenous experience, which is a lot different than, I mean, every race, every person who's been classified as a race has a different experience, but I like that BIPOC pulls
Right.
that out and like draws specific attention to that. But same, I mean, you're going to run into problems with any acronym or terminology you use unless you can, like I was saying, refer specifically to, I'm working with Black populations and you can just address that in that way. Of everything I've heard, I think BIPOC is my favorite term, but as Kheya likes to point out, it's still centering whiteness because you're white or BIPOC. And I think, the process of decentering that is going to be a long one and have a lot of interesting conversations. I don't have the answer to that, but I like to, highlight that, like it's still
Right.
centering that whiteness.
I agree with you, and I use the phrase. I have concerns about it at the same time, but and twice in recent months I've heard Indigenous Vermonters who were concerned because they felt that the phrase completely overlooks them, that they're just it doesn't draw attention to them as an individual group in a meaningful way. But
Well, and that also goes back to
yeah.
the platinum rule that Kheya was talking about. If someone
Yep.
says, I hate BIPOC, don't refer to them as BIPOC. If someone says, I'd prefer to be referred to as an Indigenous Vermonter or,
Yep.
Abenaki or whatever group it is they belong to, default to that. And if you find yourself making that mistake, like I was in a workshop on gender identity the other day, actually, and they were saying if you continually misgender someone as, what they don't identify as, so if you're calling someone who identifies as male, she, sit down and do lines, this person, Marie identifies as female or Marie is female, and just write that until it's stuck in your brain. So I think that's if you want to go back to, doing lines in grade school, that's a really useful tool.
One of the important things is that we're talking about it and trying to figure it out and trying to be respectful of everyone. One of the other questions, this is a question to each panelist. What is one example of a very concrete day-to-day thing that you would like to see happen to or for the folks you work with? You can go several ways with that question.
If I'm going to center this, I'll go first on health equity. I would like to see, and this is my accessibility hat going on, I would like to see doctors' offices and hospitals and other medical places have mammograms that are adjustable for people who are in wheelchairs or people who might be shorter statured. I'd like to see doctors' offices have tables that will go low enough so that someone in a wheelchair or someone who has issues stepping up onto that table can get there with the most amount of dignity. That would be one change in a medical system that would be amazing. And Rose, I did see your question. I'm sorry, I'm not ignoring it. I just don't know of any resource other than the Vermont Professional of Color have a directory, and I would recommend looking there, and they are online.
And I was actually going to say exactly that. So Rose, sorry, it took us a minute to circle around you. If you don't find a doc, I want to say I've seen a directory somewhere. I don't know where, so I'd have to track it down, but I will make my best effort to do that. And if you want to shoot me an email, I'll see if I can get it to you, if I can find it. If I can't, you can email the Vermont Professionals of Color Network directly, and they are fabulous about resource directing. I think it'll also depend on where you're located in Vermont, because most of them are out of Burlington. But I'm sure that they'd be able to help you find that answer if I can't track down that directory, but I feel like I've seen one somewhere.
Another question in chat from Hazel requesting information. Is there any information on organizational community readiness for change as it applies to DEI, diversity, equity, and inclusion efforts that the panelists can share? So
I
information
can
on
say for you, I feel like
organizational
I've been
community
talking a lot.
readiness.
So do Monica or Anna want to address it?
I feel like I've also been talking a lot. I can take it, but if you want to go, Anna, please.
No, you can go ahead. Thank you.
So I don't know that there's like a directory of organizational readiness, which is how I understood that question. Is that what was being asked?
Is there any information on organizational community readiness for change as it
And I
relates
think-
to
Right.
diversity, equity, and inclusion?
And the
I
way
don't
I
think
interpret
there's like
that,
sorry.
sorry, go ahead.
I think that's what we're doing. I think what we're working towards is that knowledge. I don't know that there's like a magical web page or a wand I could wave and say, yes, Rutland is ready for this change. But I think that's where we're going, is like developing, especially like that's sort of what I'm hoping comes out of this Jedi collaborative, is we assess that readiness and see where we might make our best effort.
Okay.
So, and the warrior in me is, I think for many of us in this community, I don't care if you're ready, I'm going to drag you there.
Well, the resources help people
Yeah.
move that
Oh, I know,
more
but they're just,
smoothly. Yes.
I'll be honest, because readiness for change is an important theory when you're looking at theory of change and how things move. But I think for many people in these communities is we've hit sort of a critical mass where we're tired and we're past ready for change. So we're going to start making it and drag everybody else along with us.
Okay.
The only thing I would add to that is I think change starts locally and starts with ourselves and with the communities that we interface with and the workplace environments that we work in. So I think that's exactly in large part why CVMC is committed. And I know other healthcare organizations in the state are equally as committed to advancing diversity, equity, inclusion within their organizations. The UVM Health Network has made a particular investment in that area. Again, we have a long way to go, but that's our commitment. And I think it starts with each of those steps.
And I also want to like super highlight what Anna and Kheya said, is just, it starts at an individual level and a community level. And these conversations we're having, because a big part of this culture shift that we want to get towards is just normalizing the conversation. So yes, this is a conversation we have. No, you don't need to get defensive about it if you're called on something. Here's a good resource for you. I think it's the GARE government. I'm probably going to get this wrong. I think it's Government Alliance on Race Equity or Racial Equity. has a resource. It has a bunch of resource toolkits that I highly recommend everyone go look at. It has one on normalizing these conversations.
That's the Government Alliance on Racial Equity?
I think that's what it is. I forget if it's race equity or racial equity, but it's abbreviated to GARE. If you type that in Google, I'm pretty sure that's the first thing that pops up.
So GARE,
Mhm.
that GARE?
Yes.
Yeah, okay.
And
Yeah, the
Monica's
Government
right.
Alliance on Race and Equity. I knew I was going to get that wrong.
Okay.
And Monica's correct in that this is the first step. I do a lot of work and training and speaking about having difficult conversations that shouldn't be difficult, in my opinion. But how do you have a challenging conversation and holding your mental health, your physical health, but still getting your point across? Because that's the next step for individuals, is how do we have these conversations in a manner that helps us grow and we don't hurt each other?
Mhm. Thank you. Very, very important point. So a couple more things that have been added to chat is Anna put her email address in. So you have the email address for all three of the panelists if you have additional questions for them. And Danielle put in the address for Vermont POC, vtpoc.net. So those are there also. Couple of another question that I've been given ahead of time. In addition, in healthcare and beyond, what do you think is the most important factor in making systems change to undo racism? I mean, you've gone at that in a few different directions, but the question is, what do you think is the most important factor in making systems change to undo racism?
That's a
I'll take
full
stab
loaded
at
question.
that.
I know.
I'm looking for everybody's magic wand right now, but
Yeah.
I'll take a stab
That's
at
literally
it.
where I was gonna go.
Yeah.
Like we've spent centuries getting ourselves here. This isn't we can get out of here in this hour and a half conversation. I think my first go-to would be what I just said, was normalize the discussion. The more normal you make a thing, the more accepted it becomes. So that for me is my first step in that very big question.
And like Anna, I call it my magic twanger. I wish I could like go around bopping people with it. But I think it is a lot of what I am currently experiencing, which is allies who are willing to question themselves and dig into this work, because we can't do it alone. We didn't build the system. So we need help from people who benefit from that system to realize it and start dismantling it. A really wise man in Vermont, his name's Matt Wolf, talked to me about this. He works for Vermont After School. And he said, the day that I realized that as a cis white man, if these changes happen, they benefit me too, was the day I feel like my eyes opened and I sort of understood what we're trying to get at.
Okay.
The only thing I would add to that is commitment and leadership, right? And leaders are not necessarily formal leaders with titles. It can be any one of us that take the time and are committed to making change with the people that we interface with every day. So I think it's it's a big question, but I think you take it down the way we built it, which is one step at a time and with a deep commitment to that change. And I think just the level of participation in tonight's conversation tells me that there's interest and will. So we just need to keep working on it.
Thank you. And one of the Carmen's comment in chat on this topic is it starts with the school system. So what about that? What about the schools and kids?
I feel like just like off the cuff, I think I'd have to think it through a little, but I feel like there's danger in targeting any one specific area where everything starts. That puts a lot of onus A on that system, and B, it sort of says, oh, we're focusing a lot here, so we don't have to focus here, here, and here. I don't disagree that the school system and education is really, really important, but I would caution against saying, everything starts here.
I'm not sure her comment meant literally that would be it, but that's just one of the avenues.
And I think what she might be speaking to, which is some work I'm engaged in now, which is working with the Agency of Education and looking at areas where this falls. For example, I'm advising there is a panel looking at school discipline, specifically appointed by the legislature, looking at suspension and expulsion, which we know affects BIPOC kids at an inordinate rate. And I'm not appointed to that committee, but they dragged me in because they wanted my voice and my opinion to keep them centered on some of the pieces as a representative of people of color, but someone who works with resilience and trauma. But I agree with Monika. It's not one thing, because if we say it's just the school system, then what role do parents have? What responsibility do legislators have? What responsibility do we have? Because that's the goal for me, is that we each take responsibility for this, because if everyone does, then we're going to be moving in the same direction.
Right. Yeah, and I think that the conversation that we've been having this evening has shown that there's not one single way to go about solving these issues. We haven't talked very much about legislature and laws. Are there any current proposals that any of you would like to comment on relating to health and racism?
I think the big one right now that I'm involved in is that Health Equity Advisory Council that was created by the legislature to look at this topic in depth. And it's made up of people who work for the state and people who do not work for the state. It's a very large group of people noodling over this issue and looking at, and our charge is to make recommendations and offer solutions and say if there's legislation that should happen. That work has just started. We're in month 4, maybe 5 of this.
Mm-hmm.
So it is work that's ongoing, and I can say more to come as we get more into it.
Okay, we have just a few minutes left. I'd like to give each of you, the 3 panelists, an opportunity to just to follow up any things we've talked about this evening, or to talk about any things that we haven't covered that you think we should have, or you would like us to know about, or just any other closing comments that you have. And if any of you would like to volunteer to go first, you can.
Well, I'll just start with just a note of gratitude, for everyone that committed time in their evening to listen in and be part of this discussion. Again, I think that's so important. This level of engagement is exactly what we need to make change. And I also want to thank my colleagues that are on the panel for continuing to educate me. Every time I participate in something like this, I learn something. So thank you for that. And I'm going to be reaching out to likely both of you for different reasons. So I appreciate that. And thanks for putting your contact information in the chat.
Okay.
I can hop in next if you want. So like Anna, thanks to all of my colleagues here. It's always a great learning opportunity. I love it. And thank you all for coming here tonight to listen to this and being part of that normalization. That's so key to our cultural shift. And I just wanted to highlight super quick, I forget if it was Anna or Kheya who said it, but one of you said something like, when we make something accessible for the people who access it the least, it becomes more accessible for everyone. I was just having a conversation about that a couple days ago. I forget who it was with. It might have been with someone from Ganguly-Kiefner side. But we were talking about the curb cut effect, curb cuts. So people with, wheelchairs or mobility issues can get on the sidewalk. So they put in curb cuts, and that made it more accessible for them. And it also made it more accessible unintentionally for parents with children and people pulling wheeled luggage cases and just everyone. So I don't want to say, we should only do, accessibility for everyone because it makes it more accessible for all populations, because there might be something really specific that someone needs that won't benefit a bunch of people. But I would say generally, the more accessible we can make everything and the more we can normalize, the stronger we'll all be together. So thank you all so much.
Thank you. Kheya?
And I'm going to echo both of them and say, I am so pleased with the number of you that are here. This work is hard. It's emotionally draining. And it's evenings like this where I see people of goodwill coming out and wanting to hear and ask about change that give me hope. You are the ones that keep me, and the people that I see in the marginalized communities who push me to speak, but you're the ones who keep me speaking and keep me doing this work, because you can't do it without hope. And you get hope by spreading knowledge and gathering the hope of the people that you work with or that you educate. So thank you for being here and asking the questions and being genuinely open and curious.
Okay, thank you very much. I know that I have a number of things I'm going to be able to follow up on tonight, including, I'm intrigued now, this video about microaggression and mosquitoes. So
It's a good one.
I'm looking forward to that, and a lot of other things here too. So thank you very much, Monika Ganguly-Kiefner and Anna Noonan and Kheya Ganguly and the League of Women Voters and Michelle Singer and the Kellogg-Hubbard Library. Thank you all for making this possible. And thank you for and we had more than 4 dozen people participate in the audience tonight. And also, I know there were a couple of organizations that contacted the League of Women Voters because they wanted to make sure this was being recorded, because they had members who couldn't attend tonight but wanted to watch this. So in addition to all of us who have been here tonight, there are some additional people who are going to watch this later. So thank you all very much. And Michelle, did you have something you wanted to close with?
No, other than thank
No.
you. It's a pleasure to host, and it's a pleasure to have been here.
Okay. Thank you all very much and have a good evening.
Good evening.
Bye.